Good afternoon, everyone, and welcome to the Provider Leadership Meeting for the month of June 2020. This is the first Provider Leadership Meeting that we have had for this year due to some of the coronavirus issues that we were facing, as well as just trying to work through other meetings that were on the schedule. During today's meeting, we will be having several presentations on various topics ranging from proper usage with the Medicaid spend down to various program integrity challenges, as well as conversations around reopening different aspects of the DDS system. During this presentation, just a few admin points. On your screen, your WebEx screen, on the bottom right of the participant screen, there's a little hand button, hand icon. That icon, using that icon, you can raise your hands if you have questions or if you would like to speak. Unfortunately, due to the amount of people on the call, we are not able to unmute all the lines. So I will unmute you if you raise your hand, and we can therefore have a discussion. All the presentations here are meant to be more of a discussion, so if you do have a question, feel free to raise your hand. While the presentations are being carried out, I do ask that you just wait till the end to ask any questions, but we do encourage full dialogue between all participants as we go forward. If anyone has any questions before we begin, please type it in the box now or raise your hand, and I will be happy to take them. If not, then I'm going to turn over to Hakima Muhammad, the Operations Manager here at DDS, to begin the presentation. So I'll give a minute to see if anyone has any questions. Okay, fantastic. Hakima, I'm going to add you now to begin the presentation. Hakima will be talking about Medicaid spend downs. Please just let her go through the presentation, and then she'll answer any questions, or we'll take any questions after that. Hakima, are you with us?
I am. Thank you. Good afternoon, everyone. Kirk, if you could put the presentation on the screen, and I'll just say next slide. But if we could go to the medical spend down portion of the presentation, that would be appreciated.
Yep, please bear with me 1 second.
Okay.
Hakima, the only presentation I have is the Provider Leadership Department DSLBD presentation. Is there another one that you want?
No, that's the same one. If you go to the third page on the slide, it starts the medical spend down portion.
Thank you, Hakima. I'm sharing it now.
Okay, wonderful. Thank you. Just let me know when it's okay to speak.
Okay, you're ready to go.
Excellent. Thank you. So I wanted to take a moment and just share with the provider community the process for medical spend down. Medical spend down applies when a person becomes over-resourced in assets, which according to Medicaid standards is any assets that are total beyond $4,000, or excess income, which means the person is making too much income. However, there is still a medical need. And so if we can prove that medical need, then we can get Medicaid coverage reinstated. Next slide. Thank you. So when ESA, that's the Department of Economic Security, under DHCS, evaluates a person's income, it's based upon 300% of the maximum SSI income. It's the previous slide. Thank you. So if that person exceeds the income threshold, what DDS will receive is an official medical spend down for the person. And the medical spend down documentation will describe the amount of the liability that must be met before Medicaid can be reinstated. And so we will communicate when we receive that documentation with providers, the service coordinator, and the person what the amount of the liability that must be met. The person will have 6 months to meet that liability. If they meet the liability by spending out of pocket to pay for medical items before the 6-month period lasts, then they can be reinstated at the point in which the liability or obligation was met. So the way that process works is the first day of the application month, you'll get the 6-month period. That is called your compliance period. And that's when you have to meet the medical spend down. The person's Medicaid status will stay in suspense. And what that means is they are not terminating you from the Medicaid program. However, you are not in an active status where your Medicaid card would work or you can receive benefits that will be paid by Medicaid. Our goal is to try to satisfy the liability as quickly as possible and not wait the entire 6-month spend down period. In other words, if you can meet the obligation within the first month or first week even and provide documentation that demonstrates that medical need and the amount, we will submit that to ESA for their review. So the next slide, which I'm not ready to go to just yet, I'll illustrate a case study that may make this a little bit more easier to understand and follow along. But basically, you want to provide us documentation for any unpaid medical bills that the person may have, be it prescription drugs, physician visits, health insurance premiums, any medical items that have been incurred by the provider, the person, or that DDS may have paid when the person did not have active Medicaid coverage, are all items that we can submit to ESA for their review. So these include both paid and unpaid bills. So, for example, if the provider is providing services, the Medicaid is inactive, obviously you're incurring a cost. So if you can send us an invoice of what that cost is as soon as the Medicaid coverage became inactive, we can submit that. And that can be evidence of continued medical need that goes beyond the person's income and ability to pay. Next slide, please. Thank you. So in this example that I want to share to try to make it a little bit more realistic, and again, this is just an example because everyone's obligation will be different, and ESA makes that determination. Sometimes it's $2,000, sometimes it's $3,000, sometimes it's 5 or more. But in this scenario, we're just going to use a simple example of $2,000. ESA authorizes an approved medical spend down and says the person must have qualified medical expenses of $2,000. And they can incur this over the course of 6 months. So we can satisfy this prior to the 6 months, on the first month, or any time thereof, and still have that information reviewed. So if the person submits, and I know many of you are familiar with Ms. Hall, the medical receipts, the provider invoice, or anything that remains unpaid in the first month, then ESA will look at that, but they will backdate to the first of the month so that if it is approved, the $2,000 is met, coverage will begin the first day of that month that we submit the documentation, and therefore there will be no lapse in coverage. Can you go to the next slide, please? Thank you. Here's a few examples. ESA determines that the person needs to meet $2,000 medical liability. They give the period of time, 6 months, from January 1st, 2020, that actually should say June 30th, 2020. That is the period of spend down, 6 months. So if, for example, in that first week you're providing care, you've incurred $2,000 of expenses for which you cannot bill, Then you would prepare an invoice to the person. You would provide us with a copy, and we can submit that to ESA. So if you submit that to us, let's say by January 20th, and we upload it, ESA reviews it. They decide and deem that it is a legitimate expenditure. They're now going to approve the person's Medicaid. The person's Medicaid, although it closed or went into inactive status December 31st, 2019, ESA will backdate that to January 1st because we submitted it on the 20th. And that would be if we submitted it on the 5th, the 7th, the 10th, the 20th, the 30th, or even the 31st of that month. The fact that we submitted something in that month, it will be backdated to the 1st of the month, and there'll be no lapse in coverage. This is the most ideal situation and circumstance that we would like to see for medical spend down, because it keeps your exposure limited as well as ours, as well as getting the person reinstated as quickly as possible. In the second scenario, it's the same $2,000 obligation that needs to be met. However, you don't have enough receipts that make up the $2,000. You know, you may have one physician visit that's a few $100s, a copay here, a prescription here, but it doesn't quite add up to the $2,000. So you should track those items and keep those receipts until such time as you get to $2,000. As soon as you get to $2,000, you send that receipt over to Ms. Hall, and let's say it happens to be in February, anytime in February. So there'll only be one lapse of coverage for Medicaid, which would be in January, because the same principle and process would apply. We would submit those receipts in February. If ESA says it has met the obligation and the standards and the receipts provided are adequate, coverage will go into effect February 1st. And that same philosophy applies whether you do it in March, April, May, June. You would get coverage beginning the first day of the month in which the obligation was satisfied. In the third example, you've waited the entire 6 months to achieve that $2,000 spend down. We submitted in June. You would only be eligible for June, or the person's coverage would only be eligible for June 1st. So you'd have an extensive 5 months lapse of coverage, whereas in the other examples, we're limiting the amount of time that the person does not have coverage. If you submit receipts in July 1st and after, the Medicaid is inactive. It is a completely new application. There is no ability for us to go back and recapture any of those medical claims during that 6-month period, because we have gone beyond the allowable amount of time to achieve the spend down. Next slide, please. So what are the provider responsibilities in terms of ensuring that persons' benefits remain intact? Obviously, our primary goal is to avoid a lapse in Medicaid coverage. And providers have a joint responsibility to help maintain Medicaid eligibility for the persons that we support. And the way that you can do this is, one, being aware of all the persons you support Medicaid renewal dates. You should kind of keep track of this in whatever manner that you do, of everyone's renewal date, so that 90 days in advance, you're kind of looking at your list and you're ensuring that you're submitting the proper documentation, pay stubs if the person is working. If the person is not working, uploading an MCIS, just a basic one-page Word document that says the person is no longer employed as of this effective date. Oftentimes, we're looking for pay stubs that may not exist because the person is no longer working, and we just don't know that information, and that delays the process. You want to make sure that you're monitoring the person's bank account for assets to make sure that they're not over-resourced and you're applying the appropriate spend down. You want to make sure that you're keeping receipts of any out-of-pocket expenditures that the person might have. All of those things help to assist us in the renewal and recertification process to avoid a lapse in coverage. But more importantly, once a person is under medical spin down, the faster that you respond, the faster that you meet the medical spin down obligation, the faster that you communicate with us, the faster you give us the receipts that we need, we can get the Medicaid reinstated soon to avoid a lapse. So the goal of this presentation was just to give some strategies that perhaps you can incorporate into your process to help manage the medical spin down process. So with that, that kind of concludes my presentation. I am open to taking any questions that anyone may have about the process or the information that has been shared.
Good afternoon, everyone. Just as a reminder, there's a little icon on the participants tab that has like a little hand. Please just click that if you wish to speak. If you're not finding it, you can also enter something in the chat box, and I'll open up your I'll open the line up for you to ask your questions. I'll give it a minute for any questions. Danielle, I've unmuted you. You can ask your question from RCM.
Can you hear me?
Yes, we can hear you.
Yes, I can hear you.
I was just wondering, if the person is in a residential setting, can we use a denied claim from MMIS for spin down?
Absolutely, you can. Here is the challenge with using a denied claim. You should absolutely submit claims to Medicaid, even if there's a lapse in coverage, and get that denial. But the problem is it takes 45 days to receive a denial through Medicaid, and that's time lost. So while I still would like you to do that and get the official denied claim from Medicaid as a backup of supporting documentation, if you are providing service to that person, what I want is an invoice on your company's letterhead to the person, and give us a copy of that shows a medical expenditure has been occurred and remains unpaid. So if that's, you're charging a daily rate to the person for the services you provide, if it is an ad hoc service, twice a week they're receiving some service, I would like you to begin calculating that and put that on a invoice, so to speak. And as soon as you meet the threshold of the obligation, send that to us so that we can submit it. You still do your denial claims, and we may come back and ask for those denied claims as further supporting documents. But the key is you don't have to wait 45 days, because if you do, you're definitely going to have 30 days of lapse coverage. And that cost, you're not receiving those funds. Those costs have to be paid by someone. So it is best to do it in that manner. Make sense?
Yep.
Great. Are there any other questions?
Yep. Cassandra Peters Johnson from Victory Communications. You're unmuted.
Yes. Will you be emailing us a copy of this PowerPoint or handout?
PowerPoint was sent out to all RSVP participants before the meeting. It will also be sent again after the meeting.
Okay. So we'll have this copy. You say you are emailing us this.
Yes, it was sent before the meeting and will be sent again after the meeting.
Okay. Thank you.
Jamila. Give me 1 second. Jamila Reese-Perry from CMS. You're unmuted. Hi, Jamila. Are you there? Hakima, Jamila has submitted a question that says, the 5 months that a person does not have Medicaid, who pays for expenses incurred?
That is not a decision that we can make. Everything would be taken on a case-by-case basis. And the reason for that is we have to understand why the person has been deemed ineligible. what information we sent to you and requested, and did we get that information back timely? Again, this is a collaborative effort, so that would be viewed on a case-by-case basis to make the decision whether that's something we'll cover or not. So the key is, let's not get it to where there's 5 months lapse, and that's why we're trying to give this information out. And I'm available to work with any provider should there a lapse occur, so that we can try to quickly rectify it to limit the liability to both the provider as well as DDS, and also just make sure the person is covered and can receive Medicaid benefits that they are entitled to.
Akima, I don't see any other questions. I'll give one more second for anyone who wants to raise their hands now to ask any questions.
Okay, if that's, I know I have a few more minutes and not much, but I just would like to briefly, while I have the providers, talk about the planning for year-end close, which is the last part of that slide, and just give a few quick pointers as DDS prepares for closing of our fiscal year 20. Thank you. All right, so we are the beginning stages of getting ready to close. The fiscal period ends September 30th, 2020, but we can't wait until that time to start the process. So we'll be reviewing all the purchase orders, all the items and expenses that have been submitted to us, and trying to close that out. Many of you now are familiar with the new process that we've started, which is a closeout letter that we send to you before we deobligate any funds that might be remaining on the purchase orders. And we will continue to do that process for this year. So what I want to make sure is that you have your billing person or your accountant look at all your expenditures in the given year. Make sure you have invoiced us for all legitimate claims for which you are to receive payment. You want to monitor your PO balances very carefully over the next few months. And you want to make sure that you're estimating what your projections will be on a monthly basis to ensure that that purchase order has enough funds to sustain the services you are providing persons through 9/30. As soon as you become aware that there may be a discrepancy or there may be a shortfall, you must communicate with your contract administrator so that we can review it together, come to agreement, add funds to the purchase order if necessary. But we have to do that while the fiscal year is open, because we cannot make adjustments once the fiscal year closes, and they close our pass system down even before the fiscal year ends, to avoid a lot of last-minute items. So the key here is to properly plan, project, engage to ensure that you're ready for the closeout, making sure that you invoice us every month by the 10th of the month for all previous month's expenses, so that, you're spending down on the PO appropriately and accurately, and making sure you've captured all costs. Because once we close, to go back and say, oops, I forgot to bill you for this item, well, the purchase order's closed. There's not much. We're very limited in what we can do after that point. And once we ask you to sign a closeout memo, you are attesting to the fact that you have reviewed your books, you have nothing outstanding, that you will be making no more claims, and as such, we close that PO out completely. So that's kind of just what I wanted to communicate and get everyone ready for the closeout. I'll take any questions if you have regarding the year-end close.
Hi, Akima. I could take about 2 questions just to keep us on time. There's a question from Francisca Olabi. Francisca, I am unmuting you now. You can ask your question.
Yeah, actually, she kind of answered my question when the lady from RCM asked. I was trying to get clarification that what you're saying is we should send invoice instead of waiting for denied claim, and I think you kind of explained that. But I'll give you a call later on, Akima. You know my challenges already.
Absolutely. Wonderful. I look forward to that and working with you.
Thanks, Seema. Anybody else have any questions? You can either use the question bar. I think there's something on that panel that says ask a question, or you can use that little raise hand feature. Either way, I'll give it a couple of seconds, see if anyone has any further questions. Or you can type it in the chat box if you can't find either icon. Okay, thank you.
I yield my time. Thank you very much.
All right, thanks to Hakima for that. We're going to shift now to the next section of our presentation, of our meeting. And the folks from the Quality Assurance and Performance Management Administration will give an overview of what it means to maintain quality in a time of a pandemic. So basically telling you what we are looking for from a quality perspective during this time. The folks who will be presenting are our two quality resource supervisors. Unfortunately, one supervisor is not able to join us, Tasha Klusman, but Diane Jackson, the other supervisor, will be joining. Our Quality Improvement Unit Manager, Gregory Banks, will be joining us. Our Performance Management Unit Manager, Charlotte Roberts, will be joining us. And our PCR, Provider Certification Review Manager, Barbara Stepkoyak, I'm sorry, Barbara, if I butchered your name. Barbara will be joining us for this conversation as well. So I'm going to go ahead and unmute them and join them into the conversation. There will also be a presentation. Charlotte, you are unmuted and can begin while I add everyone else.
Okay, good afternoon, everybody. Just trying to get our application up and going, but we really are thankful for you all to be here and to share some pertinent information with you. So just give me 1 second. I don't know if it may be easier for you to just share it because I don't have host access, it seems, to share application.
Okay, you should have it now.
Okay.
Are you able to share?
It's, of course, it's going slow at the one time I need it to be effective. So just bear with me, everyone. Diane, if you're unmuted, I'm sure you want to just give a quick little intro while I get this going.
Can you hear me?
I can hear you.
Greg, you're up first. So good afternoon, everybody. This is Diane Jackson, the supervisor of the Quality Resource Unit. It's great to be here with everybody. I'm going to give Charlotte a few more minutes.
I do apologize. Right there.
I can upload it as well if you prefer.
That may be quicker, Kirk, honestly. I'm really kind of freezing up over here. I apologize.
No, you're fine. So I'm going to go ahead and upload that.
So for our presentation, Greg is going to talk about the importance of reporting accurate incidents and addressing issues timely. I'm going to go over what the QRU team is comprised of and the importance of quality assurance. Barbara will tell you about what to expect with PCR during this time. And then Charlotte is going to close it out as to the new normal for quality, our national core indicators, and the changes to our internal and external committee meetings.
Okay, your slide is up and ready.
Okay.
So I think we're going to start off with Greg.
Yes.
Sure. Can everyone hear me? Am I unmuted?
Yes.
Okay.
We can hear you.
Hi, everyone. Hope everyone's doing well during these challenging times. I'm Greg Banks. I head up the Quality Improvement Unit at DDS, which consists of 5 subunits to include customer service, the formal DDA complaint system, the HRAC, RCRC, MRC, and the RRC committee. And really, I just wanted to share what we've been doing over the last few months during these challenging times. Our focus has been really to make programmatic enhancements for the end user, the DDA employees at this point. And these programmatic enhancements will aid in our efforts to improve data collection and analysis, to mitigate potential opportunities for fraud, waste, and abuse, to reduce inefficiencies, and directly and indirectly improving the quality outcomes of the people we support. We're also using programmatic enhancements to improve how the Quality Improvement Unit engages with providers. Through automation, we know we can continue to communicate more effectively, while we continue to sustain compliance measures, we have a laser focus on how we move towards a more culture of quality. Now, you may not see any of these programmatic changes for another month or two, but we're doing the internal work now, and we believe that what we're doing will actually help inform providers, not only ensuring that they meet the compliance measures, but also to ensure that we stay and remain laser focused on the quality outcomes of the people that we support. I can provide you a couple of examples of what we're working on now. We're actually taking a look at the issues resolution system. And so shortly, I think once the requirements have been gathered, you'll see a difference in how issue closure notifications come out. Typically now when you get an issue closure notification, it doesn't provide as much information as we would like. I think it just gives you the issue number along with that it was closed, but we want to be more informative. So you should see some of the differences you will see is that whether or not the issue was closed on time, what led to the delay, and also maybe some guidance on how to improve quality outcomes dependent upon the issue that was submitted. So that's what we're looking at holistically, and I can tell you on the back end, on the end users, what I'm hearing from the staff is that it does make their job a lot more efficient, and also makes data collection and analysis more seamless and accurate. So we're excited to start this process, and we can't wait to see what the fruits provide to the providers that we work along with. And that's basically it, where we are at this point. Diane?
Thank you, Greg. You can go to the Quality Resource Unit. Who are we responsible for? Our job is very unique as the Quality Resource Unit. We work collectively with all parties within DDA and DDS, which is Service Coordination, Incident Management, Contracts, Office of Contract and Procurement. So QRES is the liaison between the provider and parties within DDS. We provide technical assistance. We review your performance to ensure compliance. We also try to foster a sustainable relationship between all parties as we get involved in what's going on with certain concerns. We also monitor provider improvement and assess how your outcomes are actually played out in your agency with the people you support. Next slide. The Quality Resource Unit is comprised of about 21 people. So Tasha Kuzma and I provide oversight to 2 different groups. However, we share responsibility with the Quality Resource Specialist. I have 6 QRS and Tasha has 6 QRS, excuse me. I have the compliance specialists who are the ones who actually provide you the actual serious reportable investigation report. They input the actual recommendations as identified by the investigator into the system. And they also conduct follow-up as to investigations, recommendations to ensure that you have actually implemented them. I also have the financial compliance auditor, Juanita Brinkley Hall, who also now, that's a new position that we started last year, but she does some of what Bert Smith was doing. So Tasha also has compliance monitor. She has Charlotte King, and we have 1 vacancy. Charlotte works with our RSA providers hands-on as to what they do. And I'll give you all a brief review as to the roles of these different parties. And we have Cheryl Butler, who is new to the team. She is our Adaptive Equipment Compliance Specialist. So that is about 21 people. And of course, we have our administrative staff and Kirk. Next slide. So the Quality Resource Specialist, as you know, the team has been here probably 12 plus years. So all 12 QRS have been at the agency for a very long time, and I believe most of all providers know all of them interchangeably. The QRS are required to conduct an annual corporate review, which we continue to do. We still do environmental reviews for our supported living, ResHab, and ICS. We look at our annual day facilities to ensure that they're compliant, and of course, we look at respite sites to approve. What has been added is our bi-weekly monitoring to ensure providers are in compliance with the mayor's order that went into effect in late April. That is something that we've been working with the providers for the last 2 to 3 weeks. We just recently made some changes as to our quality review look because based on a review of what was being uploaded, we realized providers needed more hands-on technical assistance to maybe modify how they're tracking people who come in, rather essential visitors and so forth. So what you're probably going through right now is a different type of more thorough, detailed review of what you're doing as to compliance with the mayor's order. So we're going to continue providing extensive technical assistance. We're going to give you suggested ways of maybe modifying. Some providers, you have excessive questions, which is okay, that's what you want to have. But we want to make sure that you have the core requirements and how you're actually implementing it in the home and providing oversight. The QRS is required to look at your QA plans. We continue to do PPR meetings, which is great because we're doing it through Skype, Teams, and so forth. So those continue. The QRS is also still charged to look at, to go out in the community with you for IDS when that will resume, and in-home support. And we continue, and it seemed like the number of initial site visits has increased based on, everything that's going on. So we continue to do that through WhatsApp and so forth. So we're being very creative, and we continue to meet you where you are, the provider, to make sure we can answer your questions, we can look at documents, we can get pictures, videos, as to the sites to ensure that you're doing what you're supposed to do. Next slide, please. QA Compliance Monitor, that is, that is Charlotte. There's a vacancy within this area. However, Charlotte continues to work with the RSA providers to ensure compliance. She continues to do her biannual human care reviews. She continues to do the satisfaction survey, and she works very, very closely with the RSA vocational rehab counselors to ensure that she provides technical assistance and so forth. Next slide. The compliance specialists, they are Greg, Simone, and Sonia. They are certified investigators. They have been working in that position for probably over 10 years. They have extensive experience. They understand the reports, the investigations, to be able to troubleshoot and provide technical assistance to you. What we have is that we're now making we're going in more detail as to the follow-up. So you have been receiving emails from the team as to we're coming back out to ensure sustainability. So if an investigator identified several recommendations and you resolved it, of course, when you address it through MCIS, we're coming back out 3 to 6 months later, it may be less, it may be longer, to ensure that you still sustain that recommendation. So if one of the recommendations is, say, to ensure staff is trained on a mealtime plan or BSP training, we're looking to see, are you currently doing it that way? So we're not looking at the documentation that you put in the system 4 months ago, because that satisfied that recommendation at that time. We're looking to say, okay, if you have new staff in that position, is John Doe still being monitored and making sure that the staff is doing their mealtime plan accordingly? Then that's what we're saying. Yes, the provider continues to sustain and demonstrate improvement. Next slide, please. Adaptive Equipment Compliance Specialist. That is Cheryl. Cheryl is the person who oversees efforts of services for adaptive equipment needs. She reviews, she monitors, she provides technical assistance. She provides a summary status report as to new, cases, repairs, replacement, which is a very tedious job. She provides oversight and she monitors its progress. Cheryl, our AE compliance specialist, also works with representatives, from Medicaid, Medicare, and advocacies to make sure we're providing the support and making sure the people that we support receive what they need. The AE compliance specialist under Tasha as stated, and so is Charlotte King. Next slide. Financial compliance auditor, everyone's favorite role. As I said before, that started last year, and I know that has been a transition for providers because you're so used to Bert Smith doing the audit, even though we know service coordinator goes out on the daily basis, not daily basis, but they go out to review. We have the waiver unit who goes out and conducts their review. However, this is a shift for providers, and we understand that. The focus is to conduct financial audits of residential providers to, number one, ensure you are maintaining proper records. Personal care allowances are deposited timely in the person's account. Personal funds are separate from corporate accounts. Withdrawals are properly authorized and documented with receipts. And lump sum retroactive payments are properly allocated. So this is the difference of the financial compliance auditor. This position has a background in auditing and financial, which is very critical as we conduct these types of audits. And so in saying that, you'll see a different type of request, a more detailed review of the record keeping, and for us really looking at the numbers and doing a full review between 3 months to 6 months and maybe a year if warranted. So in this area, I really will emphasize to providers that if you do not have someone who has that skill level to help maintain your records for auditing, when someone comes out to audit, that is an area that you should and must improve upon. The care, I know Hakima talked about the spin down plan. Our unit will be working closely with Hakima and her staff as to monitoring that more collectively and in a collaborative manner. Juanita is out on a different detail, so that means that I'll be the one that will be actually now contacting you to actually conduct these audits. I will identify QRS who will provide support and reviews, and that should probably pick up in the beginning of July. Next slide. So overall, quality assurance, it should never stop. It continues. I know some providers had questions, will we stop doing this? Do we have to look at that? Do we need to collect this information? Yes. We're being creative in how we do it. We're being innovative in how we kind of look at records through Skype or through Skype, through Teams, what you're able to email us through a secured system until we can physically actually make that face-to-face contact, which is not coming up anytime soon, I don't think. However, quality assurance and your plan, as per the regulations, is critical to the operation. I've been at the agency for about 7+ years now, and one of the things that I've always said is that do not look to us to tell you what's wrong. Do not look to the issue system to be the sole source of identifying deficiencies. It is my expectation, and I hope it's yours, that you continue to ensure that your QA system has a plan to identify deficiencies, address them timely, and ensure sustainability. So, for example, when you hire qualified staff, you should ensure you provide training. Not training just to kind of go through the motions and say check, check, check. Training to ensure they understand the question and competency or competent to do the job. Quality assurance also means that you are randomly looking and going to the home. You're randomly asking questions. You're looking at the records, but you're documenting that you're doing it. One of the things that I keep identifying, and it's not as much as before, is that some providers have an extensive quality assurance checklist, and they do not really get to the meat of it. So, for example, if you're providing services to just a supported living home, your tool should not be designed for an ICF or a host home. You have to ensure that you understand the waiver regulations and what's required to ensure that your QA system matches the services rendered. There's also importance of minimizing underreporting of incidents. That if someone is not administering medication as required per the MAR, they are required to report those incidents and then provide training to the staff. In closing, one of the things that we're doing more so, and that's part of our PPR, our Provider Performance Review, that is conducted on an annual basis. During that review, now we're being very extensive in trying to show you as a provider, while looking at the screen, we fix the data for you. We show you, we're more transparent to let you see how we came to this count. During our continuous improvement process, which is quarterly, right, we are really looking at your QA system. So every year, we're going to keep looking at it, and HCBS. I strongly recommend that you look at your QA plan and ask somebody else to look at it and say, is it clear and precise? And can you really measure outcomes and identify deficiency? And does your tool show that you resolved it? The other thing that I identify also, that a lot of times the tools and what you do is not clear and precise. So I get that people have to handwrite on things. If you're going to handwrite, it should be legible. It should be dated. It should be clear to the person's name. It should include the home. So those are just a few things. But overall, remember that your QA plan is very vital. And if anyone wants training from Tasha and I, let us know. Thank you.
Thank you, Diane. I'm going to pause right there to see if there are any questions on what Greg and Diane presented before we continue to the rest of the quality presentation. So if you have any questions, please raise your hand on the system or enter into the chat box if you have a question, or you can use the question button. I'm not quite sure where the question button is because I have a different screen, but any one of those will work. Okay, Francisca, I see that you have a question, I believe. You're unmuted.
No, I don't. That's from the previous question.
Oh, okay, thank you. Okay, not seeing any questions, I'll continue. Thank you, Diane. So the next part of this presentation, Barbara I'm sorry, can you say her name? Stakowiak, I'm sorry. Barbara, I have trouble with names sometimes, my apologies. So Barbara was supposed to present today, but I think she's having some technical difficulties, and so I'm going to present on her behalf. The next part of this conversation is about the PCR. So many of you know, and some of you don't know, we'll resume PCRs fully on July 8th. And so we are in the process of scheduling for July, August, September at this point. And so we will try to work with all providers to use whatever remote systems you have available. As you can see here, we will primarily be using Zoom. The PCR team will be using Zoom for their capabilities and for what they plan to do. However, if Zoom doesn't work for any provider, we will also be flexible in trying to use Teams, Skype, or cell phones, or anything else that we can use. Again, just like a normal PCR, it'll be remote, but like a normal PCR, there'll be interviews with staff and people, so the people that you serve, and just to get an assessment of the certain, the various protocols and various questions for HCBS settings and other things that we have to do. Part of a PCR really involves a corporate review as well as an in-person survey that we can't do, obviously, but we'll do it remotely to just try to make sure that we're hitting the HCBS settings and asking the pertinent questions that we can during this time. This will be a modified PCR, so some of the questions that you normally receive will not be applicable during this time, and so during that, we will basically ask questions that are focused a lot more or tailored around the current public health emergency, and so I will be sharing some of those protocols with the provider community once they are finalized, but just to kind of highlight, July 8th is when we'll start up once again. So Barbara's team will be sending out announcement letters shortly to give you in advance with all providers to let you know when your PCR annual or follow-up will be scheduled. And at the same time, the team leader will talk to providers to start moving forward with what documents you will need and what systems you will need to continue the process. We will try to use what we have so far. So the PCR team has been keeping up with all of the regulations, changes, documentation, all guidances that have been released by DC Health and other agencies, all guidances that we have released. And so they will, of course, know every different change that's been put into effect, so you don't have to worry about that in any of your files. So, for example, if there was a training that was delayed due to, like, Appendix K or due to any other governing body, such as the Licensing Bureau over at DC Health, then they are aware of that, and that will be taken into account, so that you won't be dinged on that, or that won't impact your PCR score. We'll use what we have in MCIS so far, such as things that you have uploaded in response to the public health emergency, such as your CEAP and PEEPs, your continuing emergency plans and things of that nature. We'll use bank statements, some of that we have available through our current auditing system. We'll do person-centered sample and personnel requests through our interviews, and we'll ask for, send out surveys where needed for customer satisfaction. And, as I said, all indicator evidence will be modified per the current public health emergency. So you do not really have to be so concerned that you will be impacted by anything or any change that you had to make in response to the emergency. So I think that's just a general overview. I think we're going to provide more information shortly about the PCR, so, in the next upcoming weeks before July 8th. So just wanted to make sure that people had a chance to know that we are restarting it fully remote for July, August, and September, and we'll address further PCRs in the year as the current public health emergency evolves or changes. So with that, I see a question, so I'll go ahead and unmute Michael. Sorry, I can't see your last name on the screen. Michael? No. Michael,
yes. Yes, can you hear me?
I can.
Yeah, sorry, it was a question for Diane. I had typed it, so it came late. But I was just asking whenever there's an issue on MCIS, whether it's a provider issue, and we, act on it on a timely manner, respond to it on a timely manner, and the person responsible does not close the issue on a timely manner, the provider gets dinged for it. How can this be addressed?
Diane, are you here? We can hear you now, Diane.
Oh, you can hear me now? Oh.
Yes.
Hi. So you're saying that staff has not closed the issue when you've uploaded documentation timely?
Yes.
You should definitely email the person and the supervisor and Greg Banks and myself, whoever is available, to address that issue, because I know that is a concern. We're working on making some edits to the report card, because I know that some of you are concerned that it still shows as a negative on your report card, correct?
Yes, that's correct.
Right. So keep track of that like you've been doing, like how you guys would email and say this issue was actually closed timely. Now, the key is also we always have to verify that is true, but definitely keep track of that. And then on the report card, you can state that, well, my performance is not really 75%, but it's really 92%. And just keep that in your record so that when PCR or whomever comes along, you have your own internal evidence. And that's good for like quality assurance checks to make sure you're monitoring your own issues based on what we do also.
Okay, thank you.
We're working on it. Thank you.
Let me just add to that. One of the programmatic enhancements that we've made that should be already invoked and in production is when a provider uploads a document to satisfy an issue, if they've done it on time and the person who's responsible for the issue did not close it on time, the provider should get credit for actually uploading the document in a timely manner. The only time that the provider will be dinged, for lack of a better word, is if the DDA personnel who's responsible for the issue deems that the document that was uploaded does not meet the requirements, regardless if the DDA personnel closes the issue on the date that the issue is closed. But if it meets the requirements, you should not see a late issue for that, a late closure for that particular issue. So just be aware that that's part of the process. So if you're uploading the documents and it's not meeting the requirements, then you will get a late issue. But if you're uploading the document and does meet the requirements, you shouldn't see a late closure for those issues.
Correct, Greg. I think the concern is that the system has yet to change the actual outcome of that performance. So you're right. We're working to, if you upload it, it's good information. I think the concern is that it still shows on the report card that it's marked late. So like Greg, we're working on it.
Yep. All right. Thank you.
Thanks, Diane and Greg. So Charlotte, I'm going to turn it over to you for the last part of this presentation.
Great, thanks, Kirk. You can just advance the slides. And my apologies again for the earlier tech issue. Hopefully my microphone cooperates with us. So for the performance team, I know just for the past couple minutes, well, for the extent of this presentation, we've heard a lot about data and how we collect it, how we review it, how we monitor it. And even in light of this health emergency, we all are in agreement that our focus on quality assurance has not changed. Our focus on ensuring that the health and safety of the people that our agency supports is still paramount and at the forefront of all of our decisions, even though we're operating in this new work environment. So the performance unit here at DDS is in a really unique position because we have an opportunity to take all this information that we collect, whether it's from our PCRs, our issues and incidents, our recommendations, our operations data, our Medicaid claims data, and it really helps to tell the story. Are we really having effective programs and initiatives in place that help us improve the long-term health outcomes of the people that we support? So even though our methods of monitoring has changed, a lot of things have been more virtual. We're having our PCRs on Zoom, and our QRS team isn't able to physically go to provider sites anymore. But the monitorings are still very robust, and we appreciate this collaborative nature that we've had between our agency and providers to ensure that even though we're in these challenging times of just innovating in real time and on the fly, that we still ensure that our objectives and our missions of our agency are still following through. So with that, our committees are still in place to review data and escalate any issues of concern to the appropriate units within DDS. And just as a review, that's our immediate response committee that meets daily, and then our IRC core that reviews data on a look back, a 3-month basis to identify any trends in performance that really can lend itself to helping us have a better understanding of where certain supports and where resources are needed to help not only our provider community, but help to eliminate some of the problem areas that we're seeing with provider performance. We have our RCRC committee, our Human Rights and Advocacy Committee, and then overall our Quality Improvement Committee, which when we talk about interventions and we talk about improving longstanding change, we really use that QIC as an opportunity to look at the whole picture, the holistic view of DDS, and figuring out, now that we know what we can glean from our provider performance, from all the data that we're collecting, how can we then impact our outcomes so that they lead to not only meaningful outcomes for the people that we support, but also that it helps us to better understand how we can improve our entire service delivery system. Kirk, you can go to the next slide. So when we talk about understanding our service delivery system and collecting data, as all of you are aware, we do participate in the National Core Indicators Survey data collection every year. As you would imagine, certain aspects of that survey data collection have been kind of suspended just due to the nature of work. Our in-person surveying has been suspended, but we're still very much involved in our adult family survey data collection, where we send mail surveys to people with family members that receive services in their natural homes. And we're also participating in the staff stability survey, which is where you all come in and have been meaningful partners with that in the past. So we really do appreciate that. But given our current understanding of the imperative resource and the imperative need to support our direct support professionals, that was evident even before this health emergency, but even now, I mean, it's become even more at the forefront that we need to collect more information on how agencies in the local level and in our state and nationwide level can do more to provide resources to our DSP. So your participation in that staff stability survey really helps us to learn more information about it and inform our policies and procedures around providing that support to our DSPs. So those surveys are mail-based, email-based, and they're due July 31st. And as long as we can get our surveys and our portal up and running, we do hope to have those out to you all by July 1st. And then there's contact information on the surveys. And of course, if you all have questions, you can definitely reach out, and I will be more than happy to offer assistance on completing that. Okay, Kirk, just one more slide, I believe. And so back to our QIC, our Quality Improvement Committee, like I mentioned earlier, it really gives us that opportunity to collaborate. You know, we can't create policies and procedures in vacuums, and we can't assume that you all know the best practices and without having some type of interaction with the agency. So we really rely on that QIC to be that conduit of communication where we can review in real time what's happening with our data, but then kind of come with some real time, kind of initiatives that help to improve in the areas of deficiency that we're identifying. We're entering into this new normal. You know, this is the moniker that we've been tossing around, and we will for a long time. And what does that look like? You know, Diane has talked about how this is a time for us we're more relying on tech, we're being more innovative. But what does that really mean? Quality hasn't changed. The importance of quality hasn't changed, but certainly the way that we monitor and the way that we assess performance and outcomes needs to adjust a little bit to have that same type of flexibility as we go through this new time. So our next meeting is scheduled for next Tuesday, June 23rd. We'll just review some data in terms of COVID in relation to other areas of issues and incidents, just to see how COVID has impacted our other aspects of our service delivery system. It won't be a COVID-specific meeting. You know, Director Reese has been phenomenal with having these forums for us to talk about COVID in more real time. But QIC is more of in the midst of COVID, after COVID, how do we continue to ensure that quality is at the forefront, and how can we continue to collaborate to ensure that all the initiatives that we've had in place, while there has been some, it's been a steep learning curve so that we all get on the same page, but how do we both, providers and agency and all internal, external stakeholders work together to ensure that our, the health and safety of people that we support remains paramount. So that's all I have. Thank you for your time, everybody.
Thanks, Charlotte. So, you know, I just wanted to take a minute and see if anyone had any questions, further questions or comments for anyone on the team that just presented. I'll give it a minute. Okay, so I just wanted to thank the team once again, and just kind of leave this up for a second here so everyone can see the contact information for the entire team. If you have any issues or if you run into any problems with anything that we're doing, or if you have further feedback, please feel free to call me at any time. I'm Kirk Dobson, the Deputy Director for QAPMA. I'd like to thank Greg Banks, who oversees our QIU unit and is responsible for a lot of the IRC and issues. Diane Jackson and Tasha Klusman are supervisors for QRS units, who really will do a lot of the PPR, environmental and corporate reviews, and is responsible for overall provider quality. Barbara Stokoviak, who does our PCR, her information is there. And again, thank you to Charlotte for pretty much putting this together, facilitating, and she is our performance management manager. If you have any questions, especially as it relates to the national indicators, then, or anything like that, or anything having to do with the report cards, please reach out to Charlotte. Thanks, everyone. The next part of this meeting, we're going to focus right now for the next hour or so on the reopen plans for DDS and some of those folks that we serve, as well as expectations and other communications to providers on the plans to move forward. With that, I'm going to turn over to Musu Fafana, who will discuss a review of the community participation assessment and questionnaire. Musu, you are unmuted.
Hello, can you hear me?
I can.
Okay, great. Good afternoon, everyone. It's great to be here with you, and I'm going to go right into the presentation. Kirk, is it possible for me to share the content from my desktop, or are you going to pull it up?
Musu, if you prefer, you can share it from your, I'm allowing you to share it from your desktop right now.
Okay. So this will just take a minute, folks. To move away.
We can see it, Musu.
Right, I need to bring it up as a slideshow. Okay. There you go. Okay. So what I'll be presenting is DDA's Community Participation Assessment and Questionnaire. And this was a tool that was developed by a subcommittee that was convened by Director Reese to kind of look into day program reopening and to develop a consistent, uniform tool for assessing the risks involved with people's return to day programs, to pre-COVID-19 supports, or just their participation in community-based activities. And just a little bit of contextual information so we kind of look at where we are right now and the environment in which we are operating. Obviously, the COVID-19 precautions are still in place. Social distancing, minimizing people's interactions, particularly for people with serious underlying medical conditions. For more information about COVID-19 precautions, there's a website link here. And just to let you know that this information that is being shared today will be part of the training that will be done for provider staff and for service coordinators on how to utilize this tool. And so we're currently in Reopen DC Phase 1. You know, on May 29th, the mayor lifted the stay-at-home order. It means that there are several places that are open, dog parks, athletic fields. Restaurants are open with curbside and delivery services and with outdoor dining. So there are a number of places that are open in Phase 1. And hopefully we will be moving into Phase 2, which will probably be announced on Friday. And so in Phase 2, we're looking at, obviously, transit is important because we want to think about how the people we support get to the community activities of interest, how they get to their employment or their jobs. And so it is important to look at the things that are open both in Phase 1 and in Phase 2. We want to make sure that during the training that we share this information with our provider staff and with our service coordinators, because we want them to be purposeful and strategic in terms of how they plan community-based activities for people. And so additional information about Reopen DC is available at the coronavirus.dc.gov/Reopen DC website. And so what is this tool? So it is called the Community Participation Assessment and Questionnaire, and I like to call it a CPAC. It's completed prior to a person's return to day program or employment or to day supports. Now, it consists of an assessment and 2 questionnaires. And what it basically does is it identifies the risks of community participation for a person. So it looks at the situational and home-related risks. And I'll go into detail about that in a short while. And then it looks also at the person's preferences and interests in day supports, because of course DDA is a person-centered organization, and we want to make sure that throughout this entire process that we always consider what the person's preferences are. And then we look at the person's integrated support needs. What are the supports that are currently available in a COVID environment to assist this person in participating in community-based activities. Now, this CPAC, and I'm going to call it CPAC because it's really long. So what it basically does is it assists the interdisciplinary team to develop a person-centered community participation plan. And what this plan is just a summary of what the outcomes are that a person is going to be working on, what are the goals, what are the supports that are going to be needed to help this person facilitate safe, to help this person engage in safe community activities and to mitigate the risks involved. And so this tool is personalized and is customized to each person. What the CPAC is not is a directive to prevent people from engaging in activities or to preclude people from community activities based on their risks. What we're hoping is that people will identify the risks and as a team will come together and think about safe alternatives or safe ways in which this person can participate in their community. And so it consists of several sections. So the assessment section looks at situational and home risks. It looks at community preferences, and it looks at community supports. And those sections are completed by people who know the person best. We prefer that the QIDP or direct support professional who's working with the person completes that section for people that are in residential settings. For people in natural homes, it is completed by their in-home support provider. And all sections of the form obviously should be completed in collaboration with the person and or their decision maker. Now, for people that are in natural homes who do not receive in-home supports, the service coordinator completes the form in collaboration with the primary caregiver and the person. And then we have a health risks section because it is important that we understand what people's underlying health conditions are. And that section must be consistent with the responses that are on the level of need, the person's health passport, and their health care management plan. For people in residential settings, this section is completed by the provider nurse. And then for people that are in natural homes receiving in-home supports, the provider nurse or QIDP completes the section. And again, the primary caregiver or service coordinator would complete this section for people in natural homes who do not receive in-home supports. The final section of the form just lists the names and the titles of people who participated in completing the form. And obviously, we want to make sure that the person's name is listed because they should be a part of this form, of the completion of the form. And then there's a final section which verifies that the IDT team reviewed this form during the community participation planning meeting. And the form asks for the date of the team review. And so this is what the questionnaire looks like. So it starts by looking at situational and home-related risks. And that is the risks to the person, the family, the caregivers, the roommates, or others who live and engage with the person. And one of the things we wanted to do was to make this real easy for people to use. And so it's basically about circling or checking boxes. We're working on automating this tool so that it will be available in MCIS to residential providers so that their staff can go in and complete the tool. And so the first question it asks is whether the person can follow the social distancing protocol with 6 feet of distance. And obviously, people that require minimal or maximum support to follow the protocol or who refuse to follow it are considered moderate to high risk. Again, this is not about ruling out, but it is about being strategic and purposeful in terms of how we plan people's community integration activities. And then we go on to ask about the use of protective personal equipment. And again, we want to know whether people use that independently, whether they can use it for extended periods of time, whether they require minimal prompting or assistance, whether they refuse to use it or they're unable to use PPEs for extended periods. And then we look at the level of assistance required for completing activities of daily living. And again, we want to know whether the person can complete their ADLs independently. Do they require some assistance? Do they require maximum assistance from the direct support professional? In other words, does the level of assistance require close contact with a direct support professional? And then we go on and look at the people that a person lives with. Some of our folks live with roommates that they've lived with for many years. They have family members and that they care about. And so it is important to look at the people that they live with. Now, we're not saying that because a roommate has an underlying health condition that the person supported should not engage in community-based activities. But again, we want providers to be aware of this and to be purposeful in terms of how they plan. And so we ask questions. The underlying health conditions that are listed here are based on the CDC guidelines. And so, again, if there's a yes response, it means there's moderate to high risk involved with that person's participation in community-based activities, not necessarily to the person, but also to the roommates. And so we ask questions about various illnesses, and in certain situations, we ask that that the person completing the form specify, provide the diagnosis. And again, this section is completed by the provider nurse for people in residential settings. One of the questions that's important is question number 12. If not in a structured program, is the person likely to wander the community or engage in risky non-social distancing activities? And also, do they live with someone who engages in high-risk behaviors that place the person at risk for COVID-19? And then we go on to look again, we continue to look at the person's specific health-related risks. So in this section, we're not talking about the roommates, we're actually talking about the person. And again, we look at a number of illnesses, diabetes, obesity. We look at the age of the person. Are they older than 65? Are they older than 85 years old? Do they have respiratory issues? Do they have chronic kidney disease? And any other underlying health problems as specified by the CDC. And then we ask, this is a very important question, number 22, does the person miss going to the day program or to work? And what we want to do is if we have a yes response to this question, we really want to prioritize those people, because basically what will happen is, everyone is probably going to need a community participation planning meeting, because a lot of the community inclusion goals that people have do not really apply to the current environment in which we operate. And so there has to be a way to prioritize folks and to know whose meetings we're going to hold first, and whose meetings need to be scheduled as soon as possible. And so this question is going to be helpful in that regard. And then one of the things we want teams to be able to know is what is important to the person. What do they miss about their day program or work? And so there are a series of check boxes here again. There's a section where they can indicate additional information. And then we also want to know whether people are concerned about community participation. Folks are concerned about themselves, their family members. We have people that have children, they're concerned about their kids. So what are they concerned about? Whether it's going back to day program, whether it's going back to work, what are their concerns? And so there's a series of options, and also an other box where people can kind of indicate additional concerns that they may have. And then we go to question 24, which is, would increased activity outside the home reduce the frequency of behaviors or severity of the person's mental health condition? And again, that's another question with question 22 that we will utilize to kind of prioritize people's meetings and see, whose meetings they want to hold first. And then we go look at the employment supports, or the community-based supports. We want to know, what are the supports that are available, and how well can the person access or utilize these supports. So we ask about whether the person's job has adequate protective personal equipment. Can the person safely utilize available transportation options? Do they have access to the internet? Because the use of technology is going to be really important for a lot of the folks that we support. just in terms of them continuing to maintain connections with, their social connections with friends in the community, with their peers in the day program. And we also want to know whether they have access to two-way audio or video communication. And then finally, we want to include a direct quote from the person. So there's a section where the person completing the form kind of just notes a direct quote from the person or any observation, that is important to the development of a person-centered community participation plan for the person. And so once this form is completed, what are the next steps? So we're hoping to automate this form. Once it's automated, what we expect is that residential providers will complete the form, service code, and in-home support staff will complete the form in the system in MCIS. Service coordinators will be able to go in and complete the form for people who are not receiving waiver services and who are in natural homes. And once it's completed and saved, we want to make sure that the pre-COVID day support program, whether it was companion, whether it was individualized day services that they have, that they receive a copy of this form, that they receive it electronically so that they can also look at it, because the day provider needs to be a part of that community participation planning meeting. Now, what that community participation plan will look like is up to the entire team. The team has to determine that. But we think it's helpful if people can look at this plan prior to the meeting and kind of come to the meeting prepared to kind of address some of the risks that are identified in the plan. So in terms of the next steps, the team needs to consider the supports and services needed to mitigate the risk and assure the safety of the person while they are engaged in communities and activities of interest to them or employment. The team needs to develop a person-centered community participation plan that incorporates the CDC guidelines or the DC Health guidelines for people in ICFs and ResHabs. And once the team comes up with a community participation plan and everyone is in agreement, the service coordinator documents the team recommendations and the outcomes in the ISP. Any changes to supports and waiver services will be documented in the ISP plan of care, and the service coordinator will seek authorization for those services. If necessary, the person's job search or community participation plan will be amended to reflect the person's support needs and their preferences, and providers will document revised goals on the individual program plan. And then the final section, obviously, if we have this automated, we will have this section pre-populate where we want to know the names and the titles of people who completed the various sections of the form. Our IT department is currently working on it, and I think they are over like 60% complete. So the form should be ready early next week. And then the verification of team review, where the service coordinator just verifies that the team reviewed that form during the community participation planning meeting and enters the date of the review. The key points to leave with is, first, the form is not I'm sorry. Hello? Hello, Kirk?
Hi, I think that was just feedback on your end. I think we're good, yeah.
Okay. So the CPAC is not designed to exclude people from community participation. First, it's used to identify risks and assist the team with developing a plan to mitigate the risk of community participation. And if people want more information about DC's reopening stages, website link is there. They can visit that link. Once the training is complete, our Human Resource Department will be conducting trainings in the very near future on this tool for provider staff and for service coordinators. And once they have been trained, if they have questions about the tool or the assessment process, and also quality resource specialists will also be trained. And so if they have questions about the resource specialists and service coordinators will contact their supervisor. And with that said, thank you very much. And if you have any questions, please let me know. Thank you.
Thanks, Musu. So yeah, if you have any questions for Musu, please raise your hand now, or you can enter into the chat box. If you have asked the question and your question's been answered, please put your hand down if possible, or whatever it is that you do. I don't have the same screen as folks who are attending, so I can't see. But yeah, please raise your hand if you have any questions now. Or you can type in the chat box any questions that you may have. Okay, Musu, thank you so much for your presentation. I think we're going to continue the conversation now with Director Reese, who will go into a little bit of start a discussion off on the reopening plans. Director Reese.
Great. Good afternoon, everyone. As people may be aware, if you listen to the mayor's daily press briefings, it is quite likely that if everything continues to go as it has been, that we will be moving on to stage 2 on Monday, stage 2 of the reopening. And just as a reminder to people, the definition of our status in order to move to stage 2 is if there's only localized transmission of COVID-19. The Reopen DC advisory group that came together, following guidance from Johns Hopkins University, had developed a 4-stage process, with the 4th stage being that the point in time when we have an effective vaccine or cure to COVID-19. And so we're now in next week, ideally, we'll be in stage 2. And for stage 3, the definition, which we have not gotten metrics about how it will be defined yet, is that there will be only sporadic transmission of COVID-19. So the district will continue to monitor our status in terms of COVID transmission and see when we can move to stage 3. We hope to have some final guidance out to people before stage 2 actually begins. We've been working closely with DC Health. We have another conversation with them today so that we can work together on guidance that really balances for everyone and provides guidance in terms of how we support people to ensure their continued health and to limit any isolation, to allow them to the extent possible to engage in the community, to the same extent possible that any of us would wish to engage safely in the community. I'm not sure how someone else got unmuted. I thought we had control over that, but we'll identify the person in the background in a moment. At any rate, we will be.
1 second, Director. All right. I'm not sure where that's coming from, Director Reese. Can everyone just mute your lines? You should all be muted, but if you're not muted, can you please mute your line? I think our lines may be crossed. Folks, just 1 second while I try to diagnose this issue.
I'll check. Small one. Where's that? Small brain shit, you know what I mean? So I'm gonna go down and go out and check and see if they might buy them.
Everyone on the line can mute your phones. I'm not sure where that's coming from. Winslow's not part of this call, so it's not. Okay, Director Reese, I think you're better. You can continue. Sorry about that, folks.
Okay, so as I said, I'm very hopeful that working with DC Health, and also I've been working with, we have the committee that's working together with us to develop guidance for re-engaging in day services, but really it's more broadly guidance for how we continue to support people and keep them safe during the public health emergency. And so I have shared our draft with the folks on that committee as well as DC Health, and we're going to be discussing this later today with DC Health. And I just want to give you some sort of broad overviews of where we are so far so that people understand that and then be able to hear some feedback from folks. One of the things that we want to make sure of is that people are clear about who is considered at high risk. And that we are taking all necessary steps to prevent transmission, especially to those folks who are at high risk for more severe illness from COVID-19. And so we have provided, we will be providing in our guidance, not just the current definition of high risk, but also the link to the CDC website. As people know, the current knowledge of COVID-19 continues to evolve. And so that link to the website will be active, and you could check it at any time to see if any of that information has been updated. What we want to look at then, for people who are familiar with the guidance that came out from the Reopen DC Advisory Group, the kinds of placements we have at DDS are not specifically referenced there. So we have to kind of take it by analogy of, what are we closely related to in terms of the kinds of services that are provided, the kinds of people that are accessing those services, and the kinds of locations where they're getting them. And so in considering that, what we're trying to then identify is in stage 2, how do we ensure that everyone continues to be safe, and how do we make the reopen part of reopening DC a reality for the folks that we support as well? So how can they engage in various activities? One of the things that we're discussing right now, and we'll see where that lands as a final matter, is the extent to which these decisions would be made based on placement type versus an individual decision for each person based on that person's health, that person's ability to take the measures necessary to ensure their own health, and the other people that that person lives with and the kinds of risks they could pose to them as well. The reopen guidance suggests that in stage 2, we could begin having visitors again, but we're really at this stage I expect that when we issue the final guidance that we will be continuing the prohibition really on non-essential visitors, particularly to ICFs and ResHabs. What we will want to talk about is how the people who live there can have visits with people, just not having the people come in. So we'll still have, if someone came to visit, ideally the kind of thing I'd want to see would be if someone goes for walks in the neighborhood, that their visit could occur with their family member in a walk in the neighborhood. We're also still talking about the extent to which those folks could be engaging in various community activities, and perhaps they could do that with their family member as a way to visit and engage in the community at the same time. One of the things that we will be emphasizing throughout is ensuring that people recognize, I think I say this on the Friday call frequently, but maybe not frequently enough, we are really still in the early stages of this. People who are at high risk for serious outcome from COVID-19 are really not in the clear until we get to stage 4 when there's an effective vaccine and cure. So we have to stay vigilant until then in helping people take the necessary steps to keep themselves safe. So we will be reminding people of all of the necessary universal precautions they should be taking in the home, including thinking about what the rules are when people are eating together, thinking about how people share space with each other, reminding people. I expect that the Mayor's Order 2020-063, which was issued in April and provided guidance about requirements for staff and the kinds of facility-based requirements that we have for our SLs, ResHabs, and ICFs will remain in place. The kinds of things like checking staff temperatures before a shift, having staff do the questionnaire before they start their shift, ensuring that people use face coverings, all of these kinds of things absolutely will continue. Something that people need to be clear about, so DDA facility-based day programs could, in a very limited way, most likely resume some operation for up to 10 people, including staff. And this is going to be true, most likely, until, as I look at the guidance that exists now, and I don't see that changing, until we get to stage 4. So people need to be very clear about that in terms of center-based services, or even if you have a program that has community-based services, but people go there and then leave from there, you can't have more than 10 people, including staff, congregating at a place at one time. That's going to put a real significant limitation on the kinds of center-based services that you could have for a day program. In terms of people engaging in the community, this is where we're really, we'll be providing the specific guidance soon. My hope is that what we would make sure that we're doing is an individualized assessment for each person, considering that person's living situation. So that if they're engaging in the community, and I've heard some providers give very good examples throughout this, they've had some folks who are in a shared living situation and have jobs that are essential, and so they've been working throughout, and they've taken necessary measures to ensure that when the person returns from work, they're washing their hands as soon as they return and taking any necessary steps to make sure that they're not bringing anything back into the home. One of the important distinctions that I see as I say back into the home is that most of the places that DC Health licenses, and by definition, I'm sure if our lawyer is on the line, he'll correct me here, are facilities. From my perspective, the people that we support live in homes, and so we need to be able to strike that balance. In terms of people going out, it's really going to be, we'll see in terms of measuring, doing an evaluation of people's health, level of risk to them, and interest. There may be some people who are not ready to go out yet. There may be some people who are okay with staying home. So we need to make sure, as we should be making sure all the time, that we're talking here about an individualized assessment. And then walking through the kinds of things for that assessment that Musu talked in that really thorough presentation that she did. People should be aware, churches, synagogues, mosques are allowed to have services again. The guidance I'm looking at says 50 people. I'm pretty sure the mayor yesterday said 100. Or 50% of what they had pre-COVID. And so people should contact. Now, one thing to remember is that people can continue to do everything they've been doing remotely. So if that's what they're interested in, we need to make sure that we're providing the supports people need so that they can continue to the extent it's possible to maintain as much physical distance as possible. Because as I said, it's going to be a very long time before people are really fully safe to not have to worry about serious outcomes from COVID-19. And as people know, we have already, people we support have been hit hard by this. And so we really want to make sure that we're taking all the steps we need to keep them healthy going forward. Our numbers have been coming down significantly. The positive results I've seen recently, fortunately, have been the result of widespread testing, where we're identifying people who were positive but not people who were ill. And so I'm hopeful that we can continue, that you all can continue with taking the steps you've been taking to keep people safe. As I said, I hope that we will be releasing this by tomorrow evening. There is some work to do to make sure that we're all on the same page and that it's been approved, and then we will issue this guidance. But I'd be very interested to hear people's feedback now.
Director Reese, Patience Sawyer, I'm going to unmute the line for you. You can ask your questions now. Patience, are you on the line? Okay, Director Patience' question was, at what phase of the city reopening should our persons attend medical appointments with a face mask?
So, actually, at any phase, people should be, and this should have been from the stay-at-home order into phase 1, phase 2, and frankly, all the way through. When scheduling a medical appointment, we've talked, first of all, about this issue a lot, where if an annual physical is due, or any routine medical appointment is due, someone should call their doctor and talk with them about whether this appointment could be postponed, whether it could be done via some Zoom or Skype or whatever your particular physician has. The district has relaxed the telehealth requirements, so that should be widely available. But before scheduling an appointment with a doctor, when scheduling an appointment with a doctor, people should check in on the most appropriate way for that appointment to occur. And it is essential that people, if they have underlying health conditions, that they are checking in with their doctor to make sure that they're getting the kind of routine health care that they need. Because as I said, there are certain underlying conditions that put people at much higher risk for a serious outcome from COVID-19. So to the extent those can be kept under control, you know, we don't have to worry about the person having either health problems related to that underlying condition or putting themselves at risk for a more serious outcome from COVID-19. So those are questions that should be answered by their physician, and any routine appointment that's scheduled, someone should consult with the physician to talk with them about the effective way to have that appointment.
Thank you, Director. Brittany Goodwin from St. John's Community Services has a question. Brittany, I'm going to unmute your line now. Brittany, you're unmuted.
Hi, I didn't have a question. I was just letting you guys know about something earlier with the feedback.
Oh, okay, thank you.
Mm-hmm.
If anyone else has any questions for Director Reese or would like to engage in a conversation, please raise your hand, ask a question, or enter it into the chat box, and I can unmute you for the conversation.
So I see that Patience has responded that a physician is requesting the person see them face-to-face. I do know I had called my doctor about scheduling an appointment. They've changed all of their procedures about how you come in for an appointment. And so if the physician is asking to see the person, I expect they're doing the same kind of thing, where people are not sitting in a waiting room waiting to see the physician so that they're exposed to other people. You know, but have that conversation with the physician. If the physician recommends that they want to see the person face-to-face, then that should occur. Face masks are a thing. until phase 4. So whenever anyone leaves the home and goes out into the community, or when the staff come into the home, there should be face coverings. And of course, you know, once the physician's meeting with them, it's their determination about, you know, they will guide what the person needs to do.
I will follow up on that, Director, and say I've been to the dentist and a physician since we've entered phase 1, and I was asked before entering to fill out a questionnaire both times, asking if I have a temperature, have I traveled locally, domestically, or internationally in the last 14 days, is anyone I'm living with sick or tested positive for COVID-19, and several other things. The form was pretty much standard between both physicians, so I think that's pretty much standard across the physician community. I was asked to keep a face mask on the entire time, well, except for the dentist, and I did not, and the dentist did take my temperature. The other physician did not, so that's just something you could be aware of should that be required for anyone that you serve. So just thoughts to keep in mind. You know, I would ask the physician to send you the paperwork or the questions that they're going to be asking so you can be prepared for that, so you don't have to delay in a waiting room or anything like that. Any other questions for the Director, or any other questions or comments to continue this conversation and reopening? You can post in the chat box, or you can raise your hand, press the question ask button. I think those are your options. There is a question, Director, from Viviana Scott to all attendees, and she asks, with regards to fitness services, can we continue remote training with service coordinator approval?
Everything that is done currently remotely can continue to be done remotely until we get to, at least for the duration of the Appendix K, which expires March 10, 2021. As that nears an end, or if the public health emergency ends before that date, as that nears an end, we may need to look at whether there are some things that are done remotely that require approval to do them. Fitness, I don't think there's anything in our waiver rules that addresses how it's provided, and so that flexibility is a flexibility that likely already existed and isn't. This is off the top of my head, so I can confirm later, but I don't believe that's a Appendix K issue, but you're absolutely right. It's a team decision, and it should be noted in the ISP that a particular service is being provided remotely. There will be, until stage 4, until we have an effective vaccine or a cure, a preference for things to be done remotely to the extent they could be. The most we can limit personal interaction, physical interaction, the better.
And just, I'll follow up on that also, Director, and just saying the key to your question is with service coordination approval. So, you know, you really have to make sure service coordination is part of that conversation and gives you the green light for each particular case. So I think just echoing Winslow's sentiments in the past. An additional question came in, Director, from Theodore Nagachu and from Galaxy Healthcare Services. At the end, when is it going to be safe to open back up the day program?
So we do have, Musu had an excellent presentation today. We have a separate group that's looking at reopening our day programs, and so they should be able to do a presentation soon. They met this week, and they'll be doing a presentation at our committee meeting next week. Based on the guidance, as I said before, in terms of day programming that accommodates more than 10 people, including staff, I don't see that the ability to do that until we get to a point in time that there is an effective vaccine or cure. And so other than a very small program, and I can envision some small programs that I've visited that could work, it's not going to be until stage 4. It appears to me that during stage 2, for the appropriate people, we could look at that with a day program.
I think we have time for 1 or 2 more comments or questions. Again, chat box, raise your hand, or use the question button. Okay, seeing nothing else, I'm going to go on to another topic. This is not on your agenda. This is just since we have about 4 minutes. I wanted to share an update with providers on the call. I'm going to share my screen. Many of you should already know about this, but I just wanted to make sure that I highlight it here today. So I'm sharing the web page. This is the web page for Health and Human Services. It gives you details on their CARES Act Provider Relief Fund. So the deadline for applying for these funds is July 20th of 2020, which is right around the corner, just a little bit over a month. And it's a fund it's a $15 billion fund that the CARES Act put aside to provide relief payments directly to Medicaid providers. And it works out to about 2% of reported gross revenue for patient care that you've billed for Medicaid. And it requires that you submit an application. So when you go to this website that I'm highlighting right here, I'll keep it up for a little bit. When you go to that website, please make sure you go down to this link right here for apply for funding. I'm sorry, it's kind of jumping, but apply for funding and site attestation. So once you submit your application, it asks you questions such as staff size. It asks you particulars about the people you serve and what you billed for from January to December of last year, 2019. You must have been an active provider and billing at December 30th of 2019 to be eligible, but all the requirements for you to submit an application are right here. So I encourage all providers on this call, if you have not already, to go ahead and research more information and submit an application. And there are also webcasts coming up on the 23rd and 25th with more information. It's highlighted there. So for everyone on the call, please copy this URL and visit the site if you wish to engage in this program. Again, it's a $15 billion set aside from the CARES Act for each provider, and it works out to about 2% of your reported gross revenue, and it's available to all Medicaid providers. If you billed Medicaid of December 30th of last year, you are eligible. I don't really have much more information at this point. I will be releasing some more information shortly, hopefully within the next week on this after the webcast. So at this point, I don't think I can really take many questions, but I will attempt my best if I can. So with that, any questions? Okay, I'm going to stop sharing my screen. Does anyone need any more time? As a matter of fact, I'm going to actually post the URL in the chat box for all folks so that you have it. And then I'm going to stop sharing my screen now as soon as I figure out how to do that. At this point, I'm going to turn over the presentation to Shasta Brown and Robin Exton, who's going to talk a little bit about the remote supports and the utilization of remote supports under the Appendix K and the experience with it so far. So just bear with me a moment while I bring them up. Shasta, are you with us? Shasta? Shasta, can you hear us? Robin, you are also unmuted. Robin and Shasta, are you with us?
Yes, I'm here.
Hi, Robin.
Hi, good afternoon.
I think we're waiting for Shasta. I think she may be having some communications issues. Shasta, can you hear us?
I can hear you. Can you hear me?
Very well. Would you like me to upload the PowerPoint that you're going to be presenting on, or are you going to do that?
Can you upload it? Because I can't. Can you hear me?
I can.
Okay, great. Can you upload it because I
Sure can.
Thank you. Good afternoon, everyone. So Robin and I are going to be presenting on the remote support, and one of the reasons why we had opted to present on this specific topic is because, as you know, we are a person-centered organization, And every month, we opt as an agency to pick one of the PCT tools to complete as an agency to look at how things are going systemically. And our managers selected remote support services utilizing the 4+1 tool to try and see just how this service and support is actually working for people. And we received a lot of positive feedback, specifically about fitness. I heard that was one of the questions about remote support, how the Zoom meetings or the Zoom classes have been good. Overall, we heard that with the remote support, it provides people an opportunity to interact with others. And it's also increasing independence, especially for people who are utilizing remote support through supported employment. It allows people an opportunity to do things independently, but they still have their job coach to provide that verbal support and that remote support. So, but one of the concerns that the managers raised was specific to the documentation requirements that we have provided guidance for the service coordinators and the supervisors of what needs to be in the ISP when providers are requesting remote support. So this is the reason why we wanted to do this brief presentation to go over specifically the guidelines and the documentation requirements for remote support. So the next slide. Okay, so as stated by Director Reeves, everything starts with the team meeting. So prior to implementation or the discussion of remote supports or putting it in practice, you have to have a team meeting, and that must be held to discuss the appropriateness of utilizing remote supports for staffing and or clinical services. Then if the team is in agreement with utilizing remote supports, the next thing you want to do is you want to revise the lawn, because in the lawn there are specific risk factors that are identified, and you're supposed to have checked off how you're going to support the person with addressing these risk factors. And technology is one of those options. So if you're going to be supporting someone remotely, therefore, we will be using technology. You want to specifically select technology as one of the areas of how you're going to address risk factors that are identified in the lawn. Next slide. Okay, so then we're looking for the provider to provide a statement, and that statement needs to include the following: the technology to be used, the capability of the person to utilize the technology, that the technology will address all the risks identified on the lawn, the availability of the staff to administer medication if applicable, and if self-medicating, ensure the self-medication form is completed. And that's specifically for people when they have EP that support them. For the medication administration, you have to complete that self-medication form to indicate whether or not a person has the ability to do that. So if you're going to be supporting someone remotely for most of the DSP support, specifically for staffing, but someone is going to need to come in and assist the person with administering their medication, we just need to make sure we know that information. One of the things that was expressed during our 4+1 was the use of the technology. There was some concern that there has been expectations at times that if a clinician is going to be providing remote support, that the DSP is the one who's expected to use their phone to support the person through the remote support. And the DSPs at times have refused, because it's their personal phone, to utilize FaceTime for the remote support. So that's why it's very important to for the provider to identify, the technology that's going to be used, and specifically the person's ability to use that technology, and if they need support utilizing that technology. And then we just need assurance that the technology, of course, will be in the home and that it's going to be working properly. Next slide. Then for the service coordinators, they're responsible after you have the team meeting, if everybody's in agreement and they get the statement from the provider. The service coordinator is responsible for amending the ISP. So when they amend the ISP, they have to make sure they update the emergency backup plan. That's specifically if a person is going to be utilizing remote supports for staff. If staff is usually going to be there, we don't have in the backup section what the number of that staff is going to be. But if staff is going to be available remotely, we need to know who that backup plan is going to be if someone needs to get there quick, fast, and in a hurry. They also have to update the summary of recommendation section. And in that section, they have to identify the type of technology or application that will be utilized for the remote support. That could be Skype, that could be FaceTime. If it's going to be a phone call, it should be virtual, so we need to have that in there. The source of the recommendation for the remote support, and that would be the team, if the team is in agreement for the remote support, as well as what type of service will be provided through the remote support, whether it's a clinical service or direct care support service. The percentage of remote support approved by the team. As you know, Appendix K has been amended to increase the percentage of the remote support that can be provided from 20% to now 100%. So if 100% of the support is going to be remotely, we need to know that specific percentage. And then the hours and time the remote support will be provided. For the hours and time, that's even if it's clinician or if it's staff. If someone is going to be calling the person every hour to check on them, I mean, that might be a bit overkill, but just to give you an example, the hours as well as the time, it's going to be 10 o'clock, they'll check again at 3 o'clock, however that is going to be. And then the time frame and availability for remote support staff to respond in person if needed. That's part of that backup plan. We need to know who that person is going to be, but also if there is an emergency, specifically if it's the DSP that's not going to be in the home, but there's an emergency, how is that backup plan going to work and the time frame for when we expect someone to be able to support the person. The remote support timeline, duration, how long do you think this remote support is going to be implemented? Are you going to do it possibly to the end of COVID-19, the state of emergency, or if the team is figuring out, hey, this is working well, specifically for ISPs that are coming up, not just ISP amendments because we've completed those, but we now have annual ISPs coming up. The team feels as though this is something that's going to be ongoing. What is the operation going to be? And then identify the staff position to administer medication if the person is going to need their medication administered. If staff is self-medicating, ensure that the self-administration form is completed, and then the service coordinator will also have to upload that statement from the provider. And the next slide is questions. So if you have any questions for me and Robin, please, I guess they have to do the...
So they can either enter it into the chat box. If you're having trouble, you can raise your hand or you can highlight a question. I would just ask that Brittany, Francisca, Michael, and Theodore all either lower your hands or remove your question just so we can reset, because I cannot reset from this side. The PowerPoint presentations will be shared at the end of this call. Some of them were shared before, but we will be sharing them at the end of this call, after this call, I should say. Are there any other questions for Shasta or Robin? Okay, Shasta, Robin, thank you so much for that presentation. If anyone does have questions towards the end, you could always email dds.qapma@dc.gov. That's dds.qapma@dc.gov. I'll make sure that Shasta and Robin get them. Again, ladies, thank you so much. At this time, going to open it back, I'll turn it back over to Hakima Mohammed, who will introduce our next presenter. Our presenters will be from the Department of Small and Local Business Development for the District of Columbia. Hakima, give me 1 second. Let me. Hakima, are you with us?
I am. Can you hear me?
I can.
Great. All right. Well, thank you so much, Kirk. So if you could put the slide, the DSLBD portion of my slide up. And I just want to do a brief introduction as to the intent, and then I'll let my colleagues from DSLBD take it from there. Great. Thank you so much. So, if you are a DC-based business, we would like to ask, have you ever considered becoming a SBE, which is a small business enterprise?
Can you do that? Is it too late?
Next slide, please.
Okay.
Now, Mayor Bowser has a number of pathways to the middle class initiatives that ensure fair and equal pathway to the middle class. Now, some of these initiatives include the minimum wage legislation, which, by the way, providers should know that the increase to the minimum wage is on July 1st, 2020 to $15 an hour, and our Department of Small and Local Business Development, which we will hear from in a moment. So DC government is committed to ensuring that small DC-based businesses get awarded their piece of the pie for DC government contracts and can compete with larger companies. Each year, each DC agency has an established spending goal with the small business community. So for an FY20, and this is public information, DDS's approved SBE goal is $7.8 million. Now, we usually meet this goal or exceed it each year, but this year we're seeing a slightly lower than anticipated percentage as we review second quarter results. And so we want to encourage those providers who are DC-based businesses already to become SBEs through DSLBD. Not only does this help DDS meet our spending obligation with SBEs, but if you're not registered with DSLBD as a small business enterprise, then we don't receive the credit, even though we're already spending these dollars with you. So now how does it benefit you? When procurement opportunities arise in the district, if you are classified as an SBE, you receive additional preference points, up to 12 points or up to 12% price consideration. And this is designed to level the competitive field when evaluating DC government contract awards. So what this means simply is if there's a technical evaluation, SBEs will receive up to 12 preference points added to their technical scores that they would not otherwise receive. If it's on a price-only bid, and a non-SBE submits a bid for $100,000, and you're an SBE and you submitted for $112,000, guess what? You win the bid because you get that additional preference of up to 12%, all things considered. So it's an easy process to become a SBE if you're already a DC-based business. We encourage you to register your business with DSLBD, and after this meeting, we will send you the application forms that DSLBD provides. As we've looked at our provider list addresses for headquarters and all those who have DC-based business addresses and are not already SBEs, we've captured that data, so we will specifically send you those forms if there's an interest. Ronnie, are you there?
Hello, this is Ariel Giles from DSLBD. I'm the Compliance and Enforcement Manager and I'll be chatting with you all today briefly. I don't know how much more I can say to add to what has just been said by Hakima, but I'll give you a little bit about what the requirements are for becoming a CBE, what our CBE program entails, and then I'll answer any questions you might have. And so, as was just previously referenced, the Certified Business Enterprise Program is a program administered by the Department of Small Local Business Development across the district. And what that program consists of is several different designations that, oh, great, we got my PowerPoint. That'll make it even easier. So what you'll see here is just the several different designations of types of certified business. And so all businesses that are a part of this program are first local business enterprises. And so what that means is that they're located in the district. So just to quickly go over some of the certification criteria, to be eligible for a CBE certification, a business must meet some of the criteria I'm about to mention. The principal office of the business must be located in the District of Columbia. That's the very first qualifier, that this is a local business preference program. So the chief executive officer and the highest level managerial employees of the enterprise must perform their managerial functions in principal office that's located in the district. The business must demonstrate one of the following: either that more than half of its employees are residents of the district, more than half of the ownership of the business is residents of the district, more than half of the assets of the business are in the district, or more than half of the business enterprise gross receipts are in the district. And so then you'll see under these different categories, you'll see resident-owned, long-time resident-owned, but then you'll just also see this green box here for small business enterprises. And that's important to note because the program is a small business enterprise program. And you can switch to the next slide. There's requirements for agencies to meet. You just saw some of DDS's requirements for their expendable budget. That means that that's the amount of their budget that they're expected to spend with certified businesses in the district. Specifically, the goals are small business enterprise goals. If small businesses are not available to meet those requirements, then certified businesses are able to utilize certified businesses to meet those goals. And so the requirements for government-assisted contracts that are over $250,000 is that 35% of the total contract value needs to be subcontracted with the certified business if the certified business is not the prime contractor. If the certified business is the prime contractor and they choose to subcontract, they also must subcontract 35% with a small business enterprise. Right now, in response to the COVID-19 emergency, there's been an increased emphasis on small businesses in the district. And so the requirement has increased from 35% to 50% for subcontracting on district contracts. And so that's something that will continue through the emergency period, and I believe even longer. Right now, I believe the effective date will be through January 1. And so what does that mean? That means that, like I just said, 50% of the dollar value will go to SBEs, and if that's not possible, there needs to be justifications that are sent to us for those requirements to be waived. You'll see that there's also in that same COVID-19 legislation some requirements that help focus in on resident-owned businesses and disadvantaged business enterprises. So, there's a multiplier effect for a dollar spent with ROBs. Dollar spent, there's a $1.10 credit, and for every dollar spent with DBEs, disadvantaged business enterprises, there's $1.25 credit. So I'll pause here really quickly, see if there's any questions before I continue to the next slide. All right, keep it going. Can we go to the next slide? Oh, great. Oh, no, it's not up yet. Okay, here it is. Okay, so a subcontracting plan is a requirement that should be submitted with the bid before an option or extension is exercised. In that subcontracting plan, it will detail who the CBE, SBE vendors are that are going to be fulfilling the subcontracting requirement on that contract. Once that's submitted to us, any changes that will occur on a contract as far as subcontractors needs to be approved by the director of DSLBD. So basically, once you submit a subcontracting plan to us, you need to let us know if there's any plan changes, and that's what we'll hold vendors to. Once again, I already mentioned that prime contractor that is a CBE that will perform the entire contract does not need to subcontract any portion, but if they do choose to, they also must meet that 35% subcontracting requirement. Then the last slide is how to find SBEs. DSLBD has a business opportunities division that focuses on helping. This will be on the last slide. Focuses on helping vendors who may not know how to meet their SBE requirement, may need help finding certain businesses. We have a business opportunity division that can assist with that, and their information is listed here. Can we get the next slide, please? Their information is listed here at the top, so they can help with all the search requirements. The searches can be made on the website at the link above, and then once those contracts begin on a quarterly basis, we will request vendor verification forms to verify the expenditures that are being made to those small business vendors. Requires that kind of verification, and that's how we monitor those contracts and any issues that we may see around spending or in relation to the subcontracting plan. We work with the implementing agency, the contracting officer to try to verify those expenditures and really work through any issues that may arise. And so I'll pause now, and I'm happy to answer any questions.
Thank you so much for that. It was a really great presentation. If you have any questions, please enter into the chat box or raise your hand, or I think there's a question button as well.
Can you hear me?
I can, Akima.
Oh, wonderful. Thank you. So thank you so much, Ariel. We really appreciate that presentation. I don't want the providers to feel like this is a daunting task. The application is pretty simple. They will walk you through that. They'll come out and inspect your business to make sure you're really located in DC. And then once you're approved, you get a DSLBD certified number. That will be in your profile. So every purchase that's made, it gets tracked for that spending. You should know that every contract under $250,000 in the district is supposed to go to an SBE. So every contract under $250,000 goes to SBEs. Anything over $250,000 has to be shared with an SBE. So that's why we just wanted to encourage, if you're already a DEC-based business, to register with them. All right, I think we're good. Thanks so much, Ariel.
Thank you.
Hi, sorry, there was one question that came in from Theodore Nagachu from Galaxy Healthcare Services. He asked, what about if your certification CBE has expired?
Hi, yes, we can work with you to renew your CBE status. That's what the certification division can do. And so just a quick email our way and we can walk you through that process. It's very, very simple, very straightforward if your number's expired.
Any other questions? Okay, great. Hakima and Ariel, thank you so much for your presentation. That was very informative. With no other questions, we're going to continue on. Thank you. So up next, we have our colleagues from the DHCF Program Integrity who are going to give a presentation on several issues. Just give me a minute while I bring them up. Hi, Betty. I have you up so far. I don't know who's leading this presentation.
I think that is Jerry.
I don't think Jerry's with us yet. Samantha, I have you now as a panelist. You are unmuted.
Thank you. Jerry goes first, and then I will be second.
Okay. Jerry is not with us at the moment, so I guess we'll give it a minute because he's scheduled to go on at 2:30, so I'll give it a minute to have him join. I'm going to mute the phone for a minute, so kind of take a quick little break for folks, just about 3 minutes, until Gerald Wilson, the Director of Program Integrity for Division of Healthcare Finance, joins us for this part of the presentation. Please hold. Thanks, everyone. Hi, just wanted to let you know I will be sharing all the presentations with all the contact information for everyone. So I will make that available after the meeting. Thank you. Hi, so Betty, Joanna, and Samantha, you are all panelists and ready to start. I do not see Jerry, so I don't know if you want to begin without him. I have to defer to you. We are in a bit of a time crunch.
Okay.
Let me send him a message.
Okay. I already did. Do you have the slides?
I do. I'll close it out.
Okay. Anyway, please upload the presentation.
Your slides are up.
Thank you. Well, let me explain. Can you all hear me?
I'm sorry, can you repeat that?
Can you hear me?
I can, yep.
Okay, so I sent a message to Jerry, and while he gets on the meeting, I will explain what is our role from the Department of Healthcare Finance, and we are the Division of Program Integrity. Next slide. So the goal is to reduce and eliminate fraud, waste, and abuse in the Medicaid program. And we are going to give you an example of what we define as the fraud, waste, and abuse for you to understand better when we refer to. So the mission for the program is to provide a reasonable and consistent oversight of the Medicaid program. And so it encourages the compliance with the regulations, the accountability, the protection of the public funds, and the awareness and responsibility. The providers also should meet the requirements for the participation in the program, and all those services should be according with the medical necessity, and the payments should be the correct amount for the covered services, and also that the services were delivered according to the regulations. We can go to the next, and or any of my coworkers should see or receive a text from Jerry, let me know and I can stop for him to pick up. So one of our duties is the prevention, and we have also an investigations branch that deals with the complaints and basically investigations or referrals from other agencies, from beneficiaries, from providers, from other law enforcement agencies. Education, we give provider education through our audits. We also have the orientation for new providers, and we also receive calls and emails from different providers or through our Department of Provider Relations to encourage the providers to talk before they have any question on how the services should be billed or delivered. Auditing is another branch that we have in our Division of Program Integrity. And in this branch, we conduct audits for the home community-based services in this case. We have all type of audits for other providers, but in this case, the CMS requires to conduct audits, quarterly audits for the IDD services. As a result of those audits, we recover improper payments. So even if the claims have been paid already, but if we, through the audit, we determined that those payments were inappropriate, so the provider will receive a letter, a notification to pay back or recoup those monies. So that's one of the results of our audits. And the cooperation, we also work in collaboration with other law enforcement agencies like the Medicaid Fraud Control Unit. We refer cases to them, or we receive cases from them as well. And other federal and local law enforcement agencies, the FBI or the UPIC is the program integrity contractor for all the agencies in the Northeast region. Next, please. So to give you a brief overview of our Division of Program Integrity, as I said, we have the surveillance and utilization branch. We have close to 8 people, different backgrounds. One of them is a medical coding certified, and so all the CPT codes and modifiers, and he has a good experience on those. We also have 4 nurses on board to analyze the records and to determine if all of those comply with the necessity and the requirements on the regulations. We also have the investigations branch. It has also 8 investigators, and the data analytics, who is in charge of providing the analysis for all the data on the claims for the different providers, and to provide us with the resources to go on the audits and see the different trends and behaviors for the billing on the different type of providers. Next, please. This is the website, the program integrity. You can see the web portal also, and this is to give you the link for different sections that we have. One of them is the Medicaid program integrity, and you will find important information. You can familiarize with it. Next, please. And at the bottom, you click on that link, and it will take you to the program integrity. Next. Thank you. So here is how to report fraud and abuse. So you click on that link. Next, please. You will get the form for you to provide the information. And this form can be used for any person. It can be a beneficiary, it can be a provider, any person that wants to submit a complaint can use this form. So basically the form asks like what is the kind of issue that wants to be reported, and the last name and the first name and the employee agency, that's from the provider. So the information that you provide here will be used by the investigators who receive the complaint, And so I will encourage to complete as much as information you have on the issue because that will facilitate the investigation. Next, please. So we have different sections for this, and the second section is the information that receive the services. So you know the beneficiary's name, you can complete it here in this section. But as I said, if you don't know any, you can submit it anyway. But it will be helpful to have all the information. Next, please. So if you notify other agencies, in this case, if you notify DDS or any other agency, you can mark it here on this section. And this is a brief description on how the activities, how you suspect or if you're concerned to be abuse of those activities. So you can also give us a brief description. Next, please. So here is a definition of fraud. And what it makes the difference on this is that as an intentional deception or misrepresentation made by the person. So that's a good way to differentiate. And here are some examples that constitute a fraud. So like on the first example, it says that it's billing for services or supplies that were not ownership of provider. So we have providers that bill for durable medical equipment that according to them was provided, but the beneficiary never received it. So that will constitute fraud. We have examples also with dental services where the provider says that denture was delivered, but we couldn't confirm the beneficiary was received that denture. I don't know if there is on the line. I get a bit. So I will continue. So altering claims or manipulating records in order to receive higher pay amounts. So each CPT has a rate that is approved, but we have found that on the records, they increase the level of service to increase to bump CPT record, the CPT code, and receive a higher reimbursed amount. So that we also are a type of fraud. The third one is representing the nature of services for issue. So that it is in a false manner also it constitutes the fraud. The next one is the soliciting recipients for equipment that is not needed. So we have a couple of those where see that they request equipment that it was not needed. We never would find the necessity for the beneficiary to receive those services. And the last one is the completing the certificates of medical necessity for patients that never were seen by this provider. So we have cases where the physician authorized the PCS services, but when you look for claims, we found, or for records, we found that this professional never saw this beneficiary before. So it's interesting to know how the services for PCA were authorized, where never exists a professional relationship or visit with this beneficiary. Next, please. So abuse is when the provider practices are inconsistent with sound fiscal, business, or medical practices. So it can include the provider or recipient practices, because we also find from beneficiaries that abuse the Medicaid program. So it can be the provider or the beneficiary. And we can see that the charging excess for services can constitute an abuse. Submitting bills to Medicare and Medicaid that are responsibility of the other payers. We can see like workers' compensation claims that come to Medicare and Medicaid. It has another payer source. And the last one is the reimbursement for services that are not medically necessary or that doesn't meet the professional recognized standards for the healthcare industry. Next. So we have also the recipient fraud. And as I said before, we can see that is excessive use or overuse of Medicaid resources. We can see this lately. We have seen with medications and other beneficiaries using another beneficiary Medicaid ID card, or people that are not in the program using the beneficiary ID card, lending or altering, duplicating Medicaid ID, providing incorrectly eligibility or false information to provide a benefit, and simultaneously receiving benefits in DC and another state. We recently found different beneficiaries receiving services in California or in other states. Or knowingly assisting providers in rendering services to defraud Medicaid. So here is an example on how to illegally accept a payment or any type of exchange for signing time sheets or personal care services that have not been provided. And the prescription fraud for pain medications is also a good example of those, where the beneficiary gives money or another type of exchange to the provider to receive those services. Next, please. So another section that we want to describe here is the compliance plans and self-audits. So the compliance programs ensure the development for use of internal controls to monitor adherence. So we encourage the provider through their quality assurance to see if they have applicable statutes, regulations, and program requirements that can meet the compliance program. We also encourage to incorporate self-audits, and that will assist the providers with prevention to submit erroneous claims or to engage in conducts involving something that is unlawful with the healthcare program. Next, please. The compliance programs, we get a lot of questions how the providers can develop the program. And here are the components that should be included in the compliance. And as I said, in the website also we have a good section that includes them, and is the basically conducting an internal monitoring and auditing, implementing compliance and practice standards, designating a compliance officer. Sometimes we found that the quality person is in charge of this task. The other aspect is conducting appropriate training and education for all the staff, responding appropriately to detect offenses and developing corrective action. So if you, through the self-audit, detect that there is a trend or a risk, you should create a corrective action plan that you can implement and that way correct or prevent that these errors can happen again. Developing open lines of communication we see that staff sometimes report some practices that are more appropriate. So developing lines of communication among the staff is a good way to know them. And enforcing disciplinary standards through working guidelines and policies on the agency. Next, please. So this where I was telling you that I can find the provider guidance, program guidance, and you can explore it. And if you have any questions, feel free to reach to us, and we will work with you. Next, please. So we have here some resources for you. We have some worksheet for the self-audits, and you can use those, or it can be tailored for the type of service that you provide. So feel free to reach us with any question. Next, please. So here is another important information for the link to CMS. Next. And the CMS has good information for providers how to document, and you can do at your leisure any of these trainings, and it gives you a good sense how to implement those requirements. Next, please. So how we identify the audit targets. So we have an audit work plan, and some of them are mandated. As I said, CMS required to do those audits. Some of them are high-risk areas, and some of them are through data mining. So we have like those kind of different resources to plan the audits. And others are like tips and referrals, lack of compliance, that can come to us. Next, please. This is for the investigation, so I'm going to go briefly over them. So there is the hotline where you can notify also your concern, and we have also partner agencies that can help us with the investigations, and we get also referrals from the managed care organizations, and we proactively work with another BPI staff in another agencies. Next, please. So we found that something should be referred to the law enforcement. We follow these procedures, and here are the law enforcement agencies that we work in collaboration with. Next, please. So this is important because sometimes we found that the providers or the beneficiaries were not aware of the consequences. So the first thing is the provider education, but the next is the corrective action plan, the requirement of payment, other monetary penalties, and the referral to investigations, which can result in the provider payment suspension, the provider agreement termination, and possible criminal prosecution. Next. So I'm going to give you an overview of the examples of some documentation that we have within the next audit. Next, please. So here the question is, did you know these rules? It is important because Title 29, Chapter 19 in the CMR has a section on each service. Next, please. So you find each section, and I want to note here the records of confidentiality of information because it explains how the records shall be maintained. And next, please. And also for each section, how the services should be delivered. I'm giving you a tip here, and is that we plan our audits based on these requirements. So if you are familiar with them, you will be fine. So when the services includes fitness training, next please. Next, and here is another link to the provider billing manual where you find good information. Next. So wellness services talks about that each professional rendering the services shall, next please, shall comply with these 4 elements in each progress note. I highlight here the start and the end time, and next. And if you notice here on the next slide, the time was missing. Next, please. So on this part, we have the well service for 8 units, 2 hours. However, the bottom part in the duration, the progress note shows 0 minutes. So in these cases are impossible to determine or to confirm that the time billed for the services was provided. Next, please. So here on the last 3 notes, we see that it has the time, but on the last 3 notes is inaccurate, or the claims billed for 1 hour. And if you see, in addition, it's just 1 sentence, which is difficult to comply with the requirements on the regulations and to justify the 1 hour that was billed for. So Joanna will continue with the next examples, and thank you. Next, and Joanna will continue.
Hello, this is Joanna from Program Integrity. I'm also a nurse specialist. Can we go to the next slide? Hello, can you hear me? Hello?
Joanna will continue. Can we go to the next slide, please? We can hear Joanna.
Okay. Thank you.
Is it frozen? Who's controlling the slide?
Next slide, please.
So, nobody there?
Sorry, folks, we got disconnected. We're back on.
Ah, okay.
Next slide, please. Okay, so on this slide, I'm sorry, go back 1. There we go, thank you. Here are 3 examples of cancellations where claims were billed and paid for 1 hour of service. The date of service was December the 15th, 2018. And as you can see on the first note, provider did show up, but the beneficiary was in choir practice, so the service did not occur. On the second note, the provider actually showed up to provide the service, but the beneficiary was still at church. And on that third note, the provider did show up to provide services, but they declined services because they said they had family in from out of town. Because these services were not rendered, it resulted in recoupment of overpayment. Next slide. So billing for services not provided. The significance of December 25th and January 1st. Those are major holidays. So we, as we were looking at claims for this provider, we saw several claims that were billed for major holidays, particularly Christmas, New Year's, 4th of July, several. So we compared the claims against the documentation, and we noted that either documentation was missing, or we saw notes from the provider saying that the office was closed for a national holiday. And so these claims resulted in recoupment of overpayment. Next slide.
I have to interrupt you right there. We're kind of out of time, and I know a lot of people have other. I'm sorry. I know people have other commitments starting at 3. Is there a summary slide that I can go to just kind of finalize your presentation? Hello? we can hear you.
Can you hear me?
I can, yep.
Yeah. No, I mean, I think the point is we just want providers to be very aware, of the regulations and guidance when it comes to claims. And we just want to provide some examples of some issues we've seen. And our goal is to make sure that providers are aware of what they need to have. It prevents from us having to take, or you, from taking action to recoup payment. And it just ensures quality of services to beneficiaries and quality oversight so we can make sure that quality services are provided.
Thank you. So what I will do, Jerry, I will share this slide with all the providers just so they can go along and look at it. And I will also include the email addresses for you and all of your team so that if they have any questions, they can email you directly, or they can also email me and I'll forward them along.
Yeah, no, I appreciate that, and sorry for getting on late.
No, you're fine. Just in summary, I want to thank everyone for coming to the attendance today's provider leadership meeting. Our next meeting will be in August. I encourage all providers to reach out if you have any suggestions or topics you want to hear. We have the availability to reach out to our sister agencies in the district for any questions that you may have. And I'm sure they will be willing to participate or engage in any presentations you'd like to see. Again, thank you, and we'll send an invitation in August or late July for the August meeting. Thanks, everyone. I hope everyone has a great day. If you have any questions, please email me directly or dds.quapma@dc.gov. Thank you.